The interesting thing is that for most of radiation oncology, we avoid the heart. It's an organ at risk. So for treating someone's lung, we try to minimize the dose to the heart. Or for treating breast tissue, we try to find beams that minimize dose to the heart. So it's a new concept for us to be intentionally putting dose into the heart because that's where the issue is.
Normally, a resting heart beats between 60 to 100 beats per minute. But when it beats at twice that amount, that's a problem. It can be a life-threatening condition called ventricular tachycardia, or VT. For a lot of patients, VT can be tough to treat. But now, researchers are using proton beam therapy, typically used as a cancer therapy, to treat abnormal heartbeats. That's ahead on this episode of Tomorrow's Cure, a podcast from Mayo Clinic that brings the future of medicine to the present. I'm Kathy Wurzer. Thanks for being with us. We have a great lineup of guests today. I'm so excited. Dr. Konstantinos Tsiantis is a board-certified cardiologist with a specialty in cardiac electrophysiology. He's also an associate professor of medicine at Mayo Clinic. Also with us from Mayo is Dr. Amanda Deischer. She's a radiation oncology medical physicist. She's an assistant professor of medical physics and a researcher at Mayo Clinic's Comprehensive Cancer Center. We are honored that Dr. William Stevenson is with us. He is also a cardiac electrophysiologist, as well as a professor of medicine and director of the Cardiac Arrhythmia Clinical Research Program at Vanderbilt Heart and Vascular Institute. Doctors, it's a real pleasure. Thanks for taking the time to talk with us.
Thank you.
Thank you.
I know that people are probably wondering how a cancer therapy wound up being used to treat an abnormal heart rhythm. We're talking about proton beam therapy. So let's focus first on how it helps destroy cancer cells. And the science is very interesting. Dr. Deischer, can you unpack this? Proton beam therapy is a unique kind of radiation, right?
Yes. So it exists at maybe 50 centers across the U.S., one of which is Mayo Clinic in Rochester in Arizona. So proton beam therapy is different than the usual X-ray beam therapy in that the protons, depending on their energy, travel a certain distance into matter and then stop, unlike X-rays, which travel all the way through. So the way we target a tumor in the middle of the body is we use multiple beams and photons, and the tumor is caught in the crossfire, which is where that high dose is. For a proton beam, it's a particle, and so it's interacting all the way through. And with each interaction, it loses a little bit of energy and then it stops. So we can pick a particular energy, and then that particle will go a certain distance, hopefully to the end of the tumor is where we're aiming for. And then we'll dial up a different energy for protons and sort of slowly cover all of the layers of tumors.
This could sound like a simplistic question, but where do the protons come from?
So they come from in a very small bottle of hydrogen in our back room. It looks sort of like a fire extinguisher. Hydrogen is just a proton and an electron. And so the electrons are stripped off and then they're accelerated. And then the energy keeps increasing and increasing until it's the right energy for a particular patient's plan. And then we direct it down a beam line to one of 4 rooms that we have here at Mayo Clinic.
And then once the proton is targeted toward the tumor, does it just explode with energy? Is that what happens?
Yeah, so as they have these collisions are happening inside the cell. So they'll lose a little bit of energy, and that energy goes into destroying DNA or breaking DNA. And then the next time it has a collision, a few cells later, there'll be a DNA break and so on. And so there's damage done along the way, but most of its energy is deposited right as it's slowing down. So if it's a very deep tumor, we have a high energy that can penetrate 32 centimeters in water. And so when it reaches 32 centimeters, it essentially comes to a stop. The last few millimeters of a proton's track is where it does the most damage. But every time there's a little bit of a collision along the way, it does a little damage. And we paint this tumor because it's actually spots that are going back and forth. So we'll paint the deepest layer, dial back the energy, paint a slightly less deep layer all the way back. And all of this happens very quickly. It's milliseconds per spot. And we usually can deliver beams in anywhere between like 30 seconds to 4 minutes or so on average, depending on how big a tumor is.
And there's no damage to surrounding tissue.
There's some damage to normal tissue nearby, especially on the way in. But the nice thing about protons is when they stop in their tumor, there's no damage on the way out. So there's no exit path. And so if you're able to limit your entry to just a few beams, then you can spare what's behind the tumor and give it zero dose, which for some things is clinically significant if it's something sensitive sitting behind that tumor.
Does the patient feel anything
Not
during the therapy?
Not at all. You don't hear anything. You don't feel anything. It's not heat at all. The amount of heat wouldn't even heat your cup of coffee like a fraction of a degree. So no heat, no pain.
How effective is proton beam therapy in fighting cancer?
That's a good question. So it's one of the many tools in our toolbox. And for some tumors that are more radio resistant, the proton therapy helps a lot. Or for some tumors that are situated in a certain location where that lack of exit dose matters, especially for pediatric patients who are still growing and will survive their cancers and live for another 80 years, we hope, it makes a big difference for those patients. The studies are ongoing in cancer as well as to which patients benefit the most.
It sounds as though the protons are modified to carry this electrical charge targeted precisely into the tumor. Arrhythmia happens, as you all know, when the electrical signals that tell the heart to beat don't work properly. So I want to talk about that for just a moment. Dr. Stevenson, for folks who are with us, there are different types of arrhythmia, right? VTAC is what we really want to focus on. Could you explain that?
Yeah, so there are a whole bunch of different types of arrhythmias. So there are fast heart rhythms and slow heart rhythms. And what we're talking about today are fast heart rhythms. And ventricular tachycardia is a type of fast heart rhythm that we see in people who have almost any type of heart disease, usually. So it can be an old heart attack. It can be heart valve surgery. It can be something called cardiomyopathy, which is a whole group of diseases that affect the heart muscle. And what's common to many of these things is that they'll produce an area of scar in the heart. And if you have an area of scar in your pumping chambers, it's almost like having a little electrical circuit in that scar. And when the right thing comes along to trigger it, off it goes. Each time around the circuit is a heartbeat, and it can cause these episodes of sudden rapid heart action, which are ventricular tachycardia.
What does it feel like?
So what happens when you get ventricular tachycardia depends on how fast it is and how well your heart handles it. So in some people, they will feel it as rapid heartbeats, and it may not be particularly bothersome. In other people, they'll have a fall in blood pressure, and they may get lightheaded or dizzy or even faint. And then the worst case scenario is that blood pressure falls drastically, and it results in a cardiac arrest. So ventricular tachycardia is one of the causes of sudden cardiac death.
So Dr. Tsiantis, this is quite serious.
Absolutely. It can definitely be one of the most serious arrhythmias that we deal with as electrophysiologists. As Dr. Stevenson mentioned, it can be the first presentation of that arrhythmia could be a cardiac arrest and before the patient can make it to the hospital. So definitely something that can have very serious consequences for the patient.
Dr. Stevenson, what are some of the treatments currently in use for VTAC? I'm curious about that. There's medication, I'm assuming, but are there procedures?
Yeah, well, the first thing that we usually do is provide the patient with a safety net. And the safety net is something called an implanted defibrillator. So it's a little box that is implanted just beneath the collarbone under the skin. It's connected to one or more wires that run through a vein into the heart, and it watches the heart rhythm. And if the person ever has an episode of ventricular tachycardia, that little box will treat it. It will try to pace them out of it. It'll apply a little series of pacing stimuli and then stop in the hope of interrupting that circuit. If that doesn't work, then it'll give a shock, just like the paramedics would do if they found the person with a fast, dangerous heart rhythm. So that safety net works very well. The problem is that it doesn't do anything to prevent the episodes. So we really want to avoid the episodes for people that have defibrillators. So then we have a couple of options. We can give an antiarrhythmic medication to try and prevent episodes, Or we can do something called catheter ablation, which is a procedure in which catheters, long, thin wires, are inserted through the blood vessels, guided up into the heart. And we use those to try and find the scar that's located in the heart and the little electrical circuits that are in the scar, and then to damage those, usually with an electrical current to cauterize them. And those have been our two major ways of trying to prevent recurrent episodes of ventricular tachycardia in people who have defibrillators.
And Dr. Ciantis, when you are with a patient, how do you weigh which direction to go?
Yeah, well, that's evolving. The concept is evolving. In fact, we now use catheter ablation more and more earlier in the course of disease for ventricular tachycardia. It was common that we would use an antiarrhythmic medication initially before we go to an invasive procedure, but the medications themselves have a lot of side effects, and not everyone can tolerate them. On the other hand, the ablation procedures have become much more effective, quicker than they used to be. And a lot of patients respond well to catheter ablation. In part, and I have to give credit in this setting because of the pioneering work that Dr. Stevenson did, because he was there from the very beginning of catheter ablations. You know, everything that we talked about, the circuits of arrhythmias that generate VT, the models of those arrhythmias have been largely described and pioneered by Dr. Stevenson. So just putting it out there so we know who we have amongst us today. But going back to the catheter ablation, it is a procedure that, you know, we do day to day in our practice for managing the difficult ventricular arrhythmias, and patients respond well. But having said that, catheter ablation is invasive. It can be a high risk procedure for some patients. There is a risk of complications that comes with it, and we do have some challenges that come with catheter ablation. The fact is that the catheters can only reach where in certain areas of the heart, but arrhythmias may arise from scars that can be deep into the heart muscle or very close to sensitive structures that we cannot very safely ablate. Or you might have a very large area of scar that will take a long time and a higher risk procedure to completely eliminate all the potential for VT. These are some of the motivations behind developing non-invasive approaches to ablating these arrhythmias.
By the way, Dr. Stevenson, and I'm so happy that Dr. Ciantis made the comment that you truly are a pioneer in this field, and we're grateful that you're here with us. Ablation, though, do patients come back several times to have ablations? It's not a one and done situation, right?
No. Well, thank you very much. And you guys are very, very kind. You're just saying that I'm old, which I am.
Stop.
But this is a young field. So, I have had the opportunity to pretty much see the whole thing. But, one of the problems with ablation, the way that we do it presently is, in cauterizing something, it's like getting a burn anywhere. So initially there's a bit of swelling and then that heals up. So it's not that unusual that we'll cauterize an area. We think we have fixed it. Best we can tell at the time, it looks like we've got that circuit interrupted, but then when it heals up, something has recovered. So it does definitely happen that some patients were not able to adequately address the problem with ablation with a catheter through the bloodstream up to the inside surface of the heart. And we can reach some circuits from the outside that we can't get from the inside. But that's not always possible either. And there still is a fair amount of heart between those two surfaces where arrhythmias can originate from and be a problem.
This sounds quite complicated. And I wonder, do you talk to patients who are worried about a procedure like this?
Yeah, everybody's worried, of course, going into any kind of a procedure. And many of these patients, if they've had episodes of VT and if they've had shocks from their defibrillators, they're very motivated to get these arrhythmias under control. And so the risks of the procedure compared to what they are going through are usually very acceptable. There are procedure risks, kind of similar to the risks of a heart catheterization, but it's generally pretty low risk.
Why does a proton beam then work well when we're talking about targeting these abnormal heartbeats? Can we explain the science here?
So radiation is uniquely able to, come from the outside and treat large tumors that would be inside. And the thickness of a heart wall of a couple of centimeters seems large if you're trying to reach the center with a catheter, but we are used to external beams passing 30 centimeters into patients, and then being able to treat tumors that are very small with a few protons, or very large just by using more protons, more energies, larger areas. So the idea of targeting any size lesion sort of in the middle of the patient, without having to put the patient under anesthesia or any sort of access to veins or chest cavity, that sounds like it's right up our alley.
And I might want to add here, though, that protons is not the only type of radiation that we use and we have. And in fact, photon-based radiation therapy, a different type of radiation therapy, is a modality that is more widespread and has been in clinical practice for VT and, of course, for cancer for a lot longer. Having said that, that's a different modality. It does have some of the distinct features that proton doesn't have, and vice versa. Photon is much more widely available. On the other hand, photons are a little less precise in the sense of being able to navigate and target the radiation dose in a very distinct, discrete location in the myocardium.
So photon, proton, and each has challenges, but also upsides.
So both forms of radiation for VT as well as for cancer are able to deliver that high dose to a targeted area. So both can cure and kill that cancer or have an effect on that tissue that's generating the VT or enabling the VT. The difference is in the low dose that's around there, and whether that is a clinically meaningful difference or not is a big question and something that we're studying. But its ability to put the high dose in the right place is very similar. And that access issue Dr. Siontas talked about, there's so many photon machines around the US, but it'd be great if that's the best way of doing it and you don't need a proton machine, because that means more patients would have access to it.
But I think there's a global health perspective too, right? So think about our colleagues in Africa or in parts of Asia where catheter ablation is actually very difficult and very sparse because there's no hospitals or electrophysiology labs that can do that, as opposed to cancer care, where photon radiation therapy for cancer is actually very common. So imagine a model where you can radiate VT instead of having to ablate it. That globally, that could have much more impact even in places that don't have access to catheter ablation.
Dr. Stevenson, because you have been around a bit, I'm wondering, when you first heard of the teams that were looking at using, in this case, proton beam therapy on the heart, do you recall what you thought? Any initial thoughts when you first heard about the first trials?
Yeah, no, I was quite enthusiastic because we had been struggling with trying to develop different tools to reach areas that are deep within the muscle for ablation, and so this really seemed very, very promising. But of course, the other side, which is okay, if this works, what are the downsides? Nothing. We don't have any treatments that don't come with good and bad parts. And I understand very well the bad parts of catheter ablation, and I don't yet know what are the things we need to worry about as much with radiation.
Yeah. And this is definitely something that we are learning as a field. And I think we've learned more about photon radiation. The experience with protons is a lot earlier. So this is something that will keep being developed, and we will learn more in the next few years. But there's certainly risks of radiation. Radiation is invisible, but it's not benign. And that's why we use it to kill tumors, right? And even in the initial series, the clinical series that we've seen of patients treated with photons, there's certainly been some complications that we've never seen with catheter ablation. But these are the patients that were treated in those types of series are the patients who really had no other options. So we have to consider what is the type of population that we have been studying in this early first 5 to 10 year type of experience, and where we're getting with the application of this new modality for a patient population. Right now, this is a modality that we use in clinical series, in clinical indications. We use that for patients who have failed catheter ablation, who have failed or didn't tolerate the most effective, the most powerful medications. So for those patients, we have offered the option of radioablation or radiation therapy with photons or with protons. We had the opportunity to treat 7 patients here at Mayo Clinic in the last few years as part of an investigational trial that was supported by the FDA and approved by the FDA. And the initial results are promising. I wish I could say everybody was cured, but and that we eliminated all VT possible, but that wasn't the case. But I certainly think that there were some patients who benefited from radiation with protons when everything else that we did for them, including multiple catheter ablation procedures, medications, had failed.
Thank you for bringing up the clinical trial that was just completed in March of 2024.
Correct.
What are the questions that still need to be answered, do you think?
The challenge with these patients is that, as I mentioned, they had a lot of issues, a pretty advanced heart disease. So we don't anticipate those patients, unfortunately, to survive many, many, many years. So we can see the very long-term safety profile of radiation, right? The other analogy is when we treat cancer, or Dr. Deisher treats cancers in kids with protons. Hopefully, most of these young individuals survive for 30, 40, 50 years. And that has allowed the field to recognize some of those very late toxicities of radiation. Unfortunately, I don't think we're going to ever have that with radiation for the heart, for VT. But certainly there is earlier toxicities and earlier safety considerations that we have learned and we are learning, and we're optimizing how to treat those patients. We're recognizing how much is too much, how much of the area of the volume of the heart can we treat before we cause problems. How close can we treat to sensitive structures like the coronary arteries or the nerves or the stomach or the lungs? And then, very importantly, who is the best patient to receive such a treatment?
Dr. Stevenson, would you like to make any comment about this at all in terms of what questions you want to have answered?
Yeah, one of the big things that I know many groups will be working on is, how do you aim this? If we could get a catheter on the spot and cauterize it, well, we could fix it that way. But these are people where we can't get a catheter on the spot. Well, if we can't get a catheter to the area, how do we know where it's coming from? And we do have ways of making a pretty good guess about that from imaging technologies and from the electrical recordings that we do have. But this is an area of great interest in the world of electrophysiology, to be able to non-invasively identify where to aim and then to bring the therapy to that spot to eliminate these arrhythmias.
Dr. Deisher, because you have used proton beam therapy, especially when it comes to cancer patients, I'm wondering, do you have thoughts about how to aim this, especially as the two gentlemen are talking about that will be a question to answer here in the future?
So in cancer, it's often the case that you can see the tumor, physically on a CT scan, or it can be palpated in some way that you can outline where it is, or you can visualize it that way. I think these are very challenging targets because you can't look at a CT scan and tell which part is okay and which part is not. So we rely on our EP colleagues and their knowledge of reading the electrical signals of previous mapping studies, other imaging that they may be able to do of the heart to help really define inside the heart where that location is. And then from a radiation oncology and a medical physics standpoint, we can then, if they draw the target for us, and we can on a CT scan draw also all the things we don't want to hit. We want to avoid the lungs, the esophagus, the bowel, ribs, all of these things that where we know the radiation tolerance is already from 100 years of radiation oncology work. We know how to protect, normal tissue and what doses they can tolerate. And then it's a matter of getting the dose where it needs to be in the heart. The interesting thing is that for most of radiation oncology, we avoid the heart. it's an organ at risk. So for treating someone's lung, we try to minimize the dose to the heart, or for treating breast tissue, we try to find beams that minimize dose to the heart. So it's a new concept for us to be intentionally putting dose into the heart because that's where the issue is. And so we want to make it big enough that we're going to cover it even with these small little shifts, but we don't want to be so generous that we damage the normal tissue around.
And to that point, I think what gets really interesting and exciting is that we're treating non-invasively a moving target, right? So the heart is still beating, the patient is still breathing, right? So with beam, we now have the beam that's delivered in a certain location, in a certain spot on the treatment table, but the heart is moving throughout the process. And how do we make that as accurate as possible? That is exciting, innovative work that Dr. Deischer, along with the group, is doing. I think that will help even more optimize that safety and the accuracy of the treatment.
Do you think this could open the door for radioablation for other cardiac targets?
I think it's definitely, thought-provoking research. And I think there have been a lot of folks who've asked that question. Is VT the right target? It's a good place to start because we can help a population that doesn't have a lot of other options.
Historically, when we look back at the early work with radioablation for the heart, some of this work started in the atrium, in the top chambers. There was the innovation that thought that we could do atrial fibrillation ablation using radiation, and some of that was brachytherapy, so actually putting little radioactive beads into the left atrium to isolate electrically the pulmonary veins. Then there was external beam radiation for the pulmonary veins. But ultimately, I think it's the clinical need for the most challenging arrhythmias that generated the motivation to focus on the VT patients, right? In the ventricle, we still don't exactly have all the tools that we need to reach the most challenging, the deep, especially the deep myocardial sites that generate a lot of the VT. And maybe some of those catheter-based tools will come and will generate nice lesions, but they will still be invasive. So I think adding on with the non-invasive options that we're talking about today, that generates a broad spectrum of options for patients who have the most difficult arrhythmias.
Dr. Stevenson, what are your thoughts on maybe other cardiac targets?
So with time and learning more about how to safely use the technology, I do anticipate that, and atrial fibrillation is the most common cardiac arrhythmia that we deal with in adults. So a non-invasive treatment for that could be a really wonderful thing, but I think it's going to take a little while. And our treatments right now are working pretty well for a pretty good segment of that population. So I would love to see things get better. I know they're going to get better. We'll look back at what we're doing now and say, can you believe we used to put catheters in the heart to do this? And that would be wonderful if that happens, but we'll have to wait and see.
This has been really interesting. And the message I'm taking away hearing all three of you talk is that this therapy offers hope for patients who really have very few options. Dr. Siantos, what's your gut feel here? I mean, when might this be approved for clinical use?
Yeah, so in the radioablation space, the first major pivotal clinical trial is comparing the photon ablation versus redo catheter ablation. So those are patients who have already failed a conventional catheter ablation procedure, so high risk VT, difficult VT. Once that trial is completed, and hopefully we have informative results and will be conclusive as much as possible, I do think that this will generate the impetus for regulatory authorities to approve some of these modalities for more widespread clinical use.
What continues to spur you on in this work? What excites you the most, Dr. Stevenson?
Yeah, well, we've seen so much progress in the management of cardiac arrhythmias, over the past 3 decades. And if anything, it's accelerating. And the ability to give people hope who we couldn't give too much hope in the past, is really been very, very gratifying. And it's an exciting, a very exciting field. Every day going to work this is not work. This is really interesting.
Yeah. And I mean, I couldn't say any better, but, for me, I've been in the field a little less than Dr. Stevenson. And, I have learned from people like Dr. Stevenson how to manage VT and how to do this catheter ablation procedures. I think is really goes back to having more options for the patients. The most difficult ones, we've all had failures with some of the most complex, difficult catheter ablations that we do, and might spend half the day or a whole day trying to ablate a VT, and we still fail. And so what motivates me is to be able to tell the patient the next morning that we can do something else, that we can do this in a different way that will give us hope that we can manage this.
And Dr. Deisher?
I'm a medical physicist, so I don't have as much face time with patients. We're behind the scenes. But knowing that behind the scenes, we're doing our absolute best, like with the best equipment as precisely as possibly delivered, all the QA checks. We're very type A personalities trying to get it exactly right for the patients. And I think knowing that we've done our best to treat whether it's their cancer or their VT, I think it's a great feeling to come into work every day and work with a team that has that sole purpose in mind.
I thank you, Dr. Deisher, and of course, Dr. Tsiantas and Dr. Stevenson. Thank you for your pioneering work. It's really been an interesting conversation, fascinating. Thank you again for your time.
Thank you. Thanks for having us.
Thank you.
Tomorrow's Cure is a co-production of Mayo Clinic and PRX. Our producers are Deborah Balthazar and David Newtown. The show is edited by Genevieve Sponsler. Our sound engineer is Tommy Bazarian. Our theme was composed and produced by Terrence Bernardo. Tony Carlson is our production manager, and our executive producer is Jocelyn Gonzalez. Special thanks to Preston Spire for audiovisual production support. Be sure to follow Tomorrow's Cure wherever you get your podcasts. I'm your host, Kathy Wurzer. Thank you so much for listening.